So back to my goofy drawing so we can discuss it. You guys figured out right side, left side. You know, there's certain vessels that give it away as to which is the right side and which is the left side. And we can do this because the heart is actually two pumps that have been fused together. And so we are taking each pump apart, off to a side of the lungs and taking a look at some of the things that will happen, such as edema, if we actually have a pump issue. Let's start with the left pump. Oh, darn it, I did it again. The left pump. Bicuspid or mitral valve is between the atrium and the ventricle on that left side. Aorta is the big tube that takes blood to our body, or is a systemic circuit here. Now, if we had a problem with our let's start with the bicuspid or mitral valve. What if it was insufficient in its ability to close and had floppy valves, such as mitral valve prolapse, something that some people do have. And let's say it's really floppy. So that means that the blood that is pumped by the left ventricle will not all go out the aorta, correct? That means that we'll have some blood back up into the left atrium. So I want you to consider this. This is a backup system that I'm actually talking about, because if blood is going into the atrium from both the ventricle and our pulmonary veins, then what do you know about the pressure in that left atrium in comparison to normal pressure? Is the pressure staying the same? Is the pressure going up, or is the pressure going down, since now that left atrium is actually getting blood from two sources? It's going up. So if the pressure in the left atrium is going up, what is the pressure in the pulmonary veins doing? They're going up too, because they're having to put blood into a chamber that's higher, and so they're going to have their own little additional difficulty emptying that blood into that left atrium. Well, if the pulmonary vein pressure is going up, what do we know about the pressure then in the capillaries of the lungs? They're going up too. And so what we're having here is, I want you to appreciate that this valve dysfunction is causing a backup in the pressure as we go backwards to see where the blood is coming from. Well, capillaries are thin, they're delicate, they're not designed to handle high pressures. And when you put additional pressure to them, they leak. And they leak plasma into the surrounding tissue. And you can appreciate this when you actually take a stethoscope and listen to their lungs. Does anybody have any idea what you might hear if we actually listen to somebody's lungs that have leaky lung capillaries? Crackles. You'll actually hear, as they breathe in, you'll hear crackle, 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 and as they exhale, crackle, crackle, crackle. So you'll hear crackles with their respirations. So that is also referred to as lung edema or pulmonary edema, because fluid is in the soft tissues. So that's one of the things can happen. And that's just with the left atrial side. If we actually had a stenotic aorta, the aortic semilunar valves, if they were stenotic, that means how hard does the ventricle have to work to get the blood out of it? It has to work harder. And so is it going to be able to empty effectively? Its ability to empty effectively is going to be impaired because it's having to work harder just to try to empty. So the pressure in the ventricle will obviously rise. If the pressure in the left ventricle rises, what do we know about the pressure in the left atrium? It rises, pulmonary veins rises, and again, capillaries rises, and we end up with crackles or edema of the lungs. So that's where lung edema comes from. It's coming from the left pump. Are you guys following me here? So now, because most people are familiar with edema of the lower extremities, correct? You see edema around the ankles and the feet. And that typically means that there's a problem for that person. So it's obviously not a left pump issue. It therefore must be a right pump issue. And let's walk through that process too for now a right pump issue. And let's go ahead and make a stenotic tricuspid valve. If we have a stenotic tricuspid valve, how easily does the blood from the atria get into the ventricle? Not so easy. So a stenotic valve will also cause the right atrium not to empty its blood very well. Well, if the right atrium is not emptying its blood very well, what do we know about the pressure of the tubes or the veins emptying into the right atrium? Isn't there pressure going up too? So pressure is going to go up also, and it's going to go up actually a little bit more in the inferior vena cava because it has to also work against gravity, correct? Superior vena cava and stuff like that, it's got a little bit of extra, advantage because it has that gravity factor, but definitely the inferior vena cava is going to have some backup. Well, the inferior vena cava is supplying, draining blood from everything below the heart. And the thing that's the lowest in that area are our feet and ankles, correct? And so because of gravity, we're going to end up then with capillary pressure quite high, and the capillary pressure will cause fluid to leak out of the capillaries and cause edema of the lower extremities for the individual. So when you see a leg edema, that's a right pump problem. When you hear lung edema, that's a left pump problem. When you hear edema, when you see edema and hear edema, that's an entire heart problem, correct? It's both pumps are failing, and that's congestive heart failure. Most people with congestive heart failure typically have swollen feet and ankles, as well as crackles or rales in the lungs. This goofy little drawing here is very good for you guys to use to make your analysis of what happens with pressures in the system if there's some sort of valvular dysfunction. So do make sure that you talk to your friends about this. The other thing that's going to be important here is what happens if a clot breaks free. So this little diagram will also help you to figure out, because that's going to be something that I want you to actually think about on your upcoming exam. If a clot breaks free, where is it going to go? And where is it going to actually end up causing symptoms for an individual? So that's an important thing to also do as you practice with this diagram. Now we're going into cardiac physiology, and we like to start off with our microscopic anatomy or histology. And heart muscle cells indeed are short rectangular cells with a single nucleus, and it's easy to see the ends of a heart muscle cell because those ends are kind of magnified or made more obvious because they end up being intercalated discs. So we have quite a few intercalated discs whenever we have a well-prepared heart histology specimen. So they're nice and easy to see, and those are the actual ends of the heart muscle cells. Now the heart muscle cells are striated, and so they have similarities to what other muscle that we've studied? Skeletal muscle. So all of the similarities that we have, all the things that you learned about skeletal muscle are true also with cardiac muscle, except we talked about the thing that's responsible is not troponin, it's calmodulin. And so we had a different thing that was responsible for helping with cross-bridge attachment. It was the only thing. And the intercalated discs. So the intercalated discs are an interesting array of the undulating cell membrane, not basement membrane, cell membrane between the two. And they have these interesting little ways to keep things attached besides their undulations. They have desmosomes, which were like my tennis shoe things, but other people can liken them to spot welders holding the cells together. And this is designed to actually make the cell-to-cell connection very strong, so they give strength to this cell-to-cell junction. But also in here we have these guys called gap junctions. And remember, gap junctions provide a bridge or a connection from one cell to the other. so that the cells essentially can communicate with one another via these gap junctions. And our notes here state gap junctions allow ions to flow from cell to cell. And this is designed to enhance the transmission of an electrical impulse. Because these are short cells. And when one cell contracts, what it's going to end up doing is it's going to end up causing a domino effect of all the cells that are basically connected to it via gap junctions. They're all going to contract, and in a basically a domino-like fashion. So these gap junctions are very important in allowing the heart muscle to act like it is a single unit that is going to contract all at once. And so we know calcium entry and sodium entry is going to be very important in causing that muscle to contract. And so we don't have to have it come all from the outside. We can actually transmit the electrical impulse from cell to cell just by activating one cell in this domino effect. Not in your notes, but you need to add to your notes not just many mitochondria, which is more than skeletal, plus lots of myoglobin. Do you guys remember what myoglobin's for? It's for oxygen. So not only do our cells, our muscle cells that have myoglobin get oxygen from hemoglobin in the bloodstream, they literally can store oxygen inside their cells. And this is real important because heart muscle cells, when they're contracting, do they actually get any oxygen from the blood? They're not. So it's really nice to have a little myoglobin bank from which to actually get your oxygen when you need it, when you can't get it from the circulation or external sources. And it's easy to refill that myoglobin bank because when you relax, you get adequate perfusion because remember our coronary ostia now are open and blood is flowing into the coronary ostia and actually into the myocardium, and we're able to actually then replete our myoglobin stores. Differences between skeletal muscle and cardiac muscle. All or none. We said skeletal muscle cells are all or none in their contraction. Well, what's really interesting, cardiac muscle cells, indeed, when one cell contracts, indeed the entire heart is guaranteed to contract. So that's a little bit different. It's not just a cell, it's all or none for the heart muscle itself. The other interesting thing about the heart muscle, it was born to beat. And so it has automaticity. And we have some very specialized cardiac muscle cells that can actually initiate their own depolarization, and we're going to talk about that in just a moment. So very specialized cells that act like basically the heart muscle's neurons, built-in neuron system to stimulate the muscle cells to actually contract. Another interesting thing that heart muscle cells have is that they have a very long refractory period. Skeletal muscle cells, only 1 to 2 milliseconds. Heart muscle cells, 250 milliseconds. And that refractory period means that the muscle cell cannot contract. It has to relax during that time period. And that's really, really excellent for us. First, it helps to prevent tetany of the heart itself. And the other thing that it does, it helps to ensure proper filling of the heart. So those two things are actually really a great side effect of having a really long refractory period. Now, 250 milliseconds is still pretty darn short, but it's enough for things to actually work out the way it's supposed to for filling of the heart and to keep from actually having that tetany occur. Now we're going to take a look at the mechanism of contraction. And I want you to remember all action potentials are similar in our excitable tissues. So all APs similar in our excitable tissues. So let's go back to the nervous system. So what does a neuron have to accomplish in order to have an action potential? You guys remember? It has to get to threshold. And we went from minus 70 to minus 55 millivolts, correct? Minus 55 millivolts was our example for threshold for a neuron. Once it gets to threshold, we get a guaranteed action potential. What helps us to get to threshold? What ion is responsible for that? Sodium. And also, isn't sodium also responsible for the remainder of the upward spike on our action potential? And it's a sharp upward spike, and once we hit positive 30 millivolts, which was a 100 millivolt difference, minus 70 to positive 30, our sodium gates closed, and what opened? Potassium. And we went right back down to resting membrane potential, and a little bit of an overshoot, but that's okay. So we always have an upward spike, and we always have a downward spike, and the spikes are ion specific, correct? So all of that is similar here in our skeletal muscle as well as our cardiac muscle. But here is a little bit of some differences here with cardiac muscle cells. Now, this is not the automatic system, but this is cardiac muscle cells. Okay, action potential hits the muscle cells, okay, and sodium gates open, and this is going to depolarize the cell, which is what we're used to, so nothing different there. Sodium gates close, and then potassium gates open. And this is all due to reaching that positive 30 millivolts. This is voltage dependent. Both of these steps, which is what we are used to with our neurophysiology. But here is something that's a little different, but not too different, because remember when we got to the axon terminal, in order to exocytose our neurotransmitter, we had to have calcium entry to help with those vesicles fuse with the membrane. So this part here isn't actually something that we haven't seen either before. But what's interesting here, it says calcium gates open, and this is again voltage dependent. But these calcium gates stay open and create what's called a plateau period. Much longer than we're used to. They stay open and create a plateau. And the reason they create a plateau is we're used to it actually going straight down. But now we have so many calcium gates opening, and there's things as slow calcium gates and fast calcium gates, and let's not go into slow or fast. Let's just say calcium gates are opening, and so many are opening that it's a positive charge they're bringing in, right? And is calcium one positive charge or two? Two. So they're bringing in two positive charges, and so even though our potassium's leaving, we got so much calcium coming in that we don't go down, we actually create a plateau, which is very different from what we're used to actually seeing. Then we'll get enough of a change in voltage that calcium gates close, and then this is also due to voltage. So we got lower than the voltage that caused us to open, and when the calcium gates close, now we are going to be able to start our depolarization. Start repolarization. And that's what the potassium gates are all for. Potassium gates remain open. This is repolarizing our cell. back to RMP, resting membrane potential. So we're going to draw this because this looks different, because a normal action potential is we have resting membrane potential. We have a little bit of something causing things to go in, and then we hit our threshold. We get a nice sharp spike, a little overshoot, and then we're back. That's a typical action potential. And it's probably easier for you guys to draw it on your own paper. But let's go ahead now and draw the picture that we just talked about. So resting membrane potential, and we're going to have sodium gates opening to depolarize the cell. So we are having our cell to depolarize, going nice up. And now sodium gates are going to close, potassium gates are going to open, and calcium gates open. And now we get this kind of wonky, blocky look to things. So upward spike, hit our peak, sodium gates close, potassium gates open, but calcium gates are opening too, and we get a wonky looking to our block, and finally get to that voltage area where calcium gates will close. So on our picture here, this side is meant to be A, this peak is meant to be B, this plateau is due to C, D is happening here, and E is taking us back down. So we got a block instead of a nice spike. And so we have a longer time that we are actually up there at a depolarized level than what we are used to with our neurons. Yes?
Is the neuron hyperpolarized? Let's go back down.
This is a heart muscle cell, and so we don't get the hyperpolarization with the heart muscle cell. We'll talk about the conduction system next, because that's what we're actually leading up to. So now we're going into the conduction system of the heart. So excitation and electrical events. And the heart has its own built-in conduction system, so to speak. And that's what intrinsic is all about. We also have extrinsic control of our heart rate, but the heart was born to beat. And we're going to take a look at how the heart actually has so many backup systems to ensure that it beats. It may not be beating efficiently, but the heart was born to beat. And if you watch those lovely zombie movies or vampire movies where they have gore and more, and somebody reaches into somebody's chest and pulls out a heart, in order to improve the realism of those things, that heart should be beating when they've pulled it out of their chest. Because literally, when you take a heart out of a living person right away, that heart is still beating. And it will continue to beat for a period of time until it exhausts its reservoirs. And that's another reason why we can transplant hearts, because they were born to beat, and they will beat until they've exhausted their reservoirs. And so whenever we do heart transplants, we don't want them to exhaust their reservoirs. What do we do with them? We put them on ice, because we want to slow them down as much metabolically because they're still alive. And then we're able to then put them into a person, as long as we get them into that person under ideal circumstances, which is obviously time dependent. But the heart muscle is an incredible muscle, and it indeed is born to beat. And what's interesting is when you rip it out of somebody's chest, you actually rip out the extrinsic controls. And when you put it into somebody else's chest, it will establish its normal heartbeat rate, which is without any other sympathetic or parasympathetic nervous system telling it what to do. Its intrinsic rate is 100 beats a minute. As you sit here, is that your intrinsic heart rate right now? No, it's being modified by external factors, and so we'll talk about what modifies the heart rate externally. That's the extrinsic controls of the heart. But the heart is designed to beat, and it's so well constructed in its desire to beat that it has backup systems. So if one system fails, we have a second system. If the second system fails, we actually have a third system that will help the heart to beat. So let's take a look at the intrinsic conduction system of the heart. Action potentials, APs, are generated by non-contractile cardiac cells. So these are heart muscle cells that aren't really muscle cells. They are actually cells designed to conduct electrical impulses. So this is the wiring, the internal wiring of the heart. And these non-contractile cardiac cells belong to what we call the nodal system. And this nodal system provides is the pacemaker of the heart. What's interesting about these specialized heart muscle cells is they are going to generate action potentials, and they have an unstable resting membrane potential. So resting membrane potential, we're going to just stick with what we've learned for neurophysiology. I'll just let you guys know that if you go into any sort of cardiophysiology or other myophysiology, the resting membrane potential will vary for the cell type that you're actually looking at. So we're used to minus 70. Well, some other cells will have a minus 80 or minus 90, things along that line, but they all function the same way. The principles are all the same, and so it's not important that we know the exact number for the resting membrane potential. But when I tell you that it's unstable, am I telling you it stays at whatever it is, and we'll just use 70, minus 70. Does it stay at minus 70 if it's unstable? It changes, and that's what's important here. The unstable resting membrane potential is what will actually create the pacemaker potential, because in these cells, they are more leaky to sodium than they are to potassium, significantly so. So they have more sodium leak channels than they do potassium leak channels, which means sodium likes to go where if we have a cell with a bunch of leaky sodium channels in it? Where does sodium like to go? In. And where does potassium like to go? Out. So what this is telling you, this is meant to let you know, we'll say we're starting at minus 70 millivolts, but because we are so leaky to sodium, we go from minus 70 to minus 69 to minus 68 to minus whatever until we get to possibly minus 55 or what is considered threshold. And that is because we are so leaky to sodium and not to potassium. If we were equally leaky to both, our resting membrane potential would actually be the same, and our sodium-potassium pumps would be putting everything back where it belongs, correct? So that's what's interesting here. Increased sodium linkage is telling you these cardiac muscle cells, these specialized cardiac muscle cells, allow sodium entry. And then because we don't have a lot of leakage to potassium, less potassium out plus more sodium in gives us to threshold. And that threshold there, and this whole process, is a pacemaker potential. Remember, we've talked about action potentials, graded potentials, postsynaptic potentials. Now we have another potential. It's called pacemaker potential. And leaky sodium gets us to threshold, and then we have our action potential. And that's what this part in our note says here. Threshold is reached, action potential actually occurs. What's interesting here is when threshold is reached, the action potential is not due to sodium entry. So wait a minute. That's what we're used to. Well, we're having some sodium entry, but it's not like the rapid sodium entry that we're used to. What actually is happening now is when threshold is reached, we get calcium channels suddenly open. When we get to threshold, calcium channels will open, and this is the actual major ion responsible for the depolarization.
But threshold is actually a result of the sodium.
Threshold is is the effect of sodium leakage. So the pacemaker potential is a sodium issue, but once threshold is reached, calcium is the main player for the action potential or the depolarization that we're actually used to. So sodium is still coming in. Sodium entry is still occurring. But not main player, not the main reason for that nice upward action potential that we see in our pacemaker potentials and action potentials. Calcium gates will still open to repolarize the, potassium gates will still open to repolarize the cell, and calcium gates will close. Both of these are voltage dependent. So our reason for potassium gates opening has never changed, correct? And our sodium gates have always played a big role in actually helping us to get an action potential going. But this one's different for our cardiac pacemaker cells. They are very calcium dependent. This is another reason why normal ionic balance in your blood is actually very important for you. We talked about parathyroid hormone, responsible for helping us to maintain normal blood calcium levels. And this is another of the big reasons that we actually have to have proper blood calcium levels in order for the heart to actually beat properly because of its system. So now when we actually draw our pacemaker potential, we'll still have our resting membrane, RMP, resting membrane potential down here. But now what we're going to do is we're going to have a slope. And that slope is sodium dependent. So this is a leakiness of our sodium in these excitable cells. And now we hit our threshold and we go up and we go down. And so what we have here, when I look at this the other day, I was going, wow, this is different, you know. It doesn't look like our usual neuron action potential, does it? But you know what? What if you took a neuron's action potential and pulled it and lengthened it, made it, magnified it? It almost, to me, almost looks like a neuron action potential that's been kind of stretched apart. Because we know for a neuron, we do have a short time period where sodium is coming in to actually give us our threshold, and then we get that upward spike and downward spike. But in this process, this upward spike here is all calcium. As far as we're concerned, this downward spike there is all sodium, or upward slant is all sodium, and then this downward aspect is all potassium. So calcium is the one that actually is different from what we're used to. And that's what pacemaker action potentials look like. So let's take a look at the cells, the intrinsic conduction system of the heart and cells in the various locations to see how this gives us our heartbeat. SA node, sinoatrial node. It's in our right atrial wall just below our superior vena cava opening. It is a histological structure. So when I tell you it's a histological structure, can you see it with your naked eye? No. You can't see it, you can't feel it, you don't know anything about it. But I will tell you, on some of these pig hearts, I don't know if some of you, when you were actually dissecting out your right coronary artery, notice that there was a teeny tiny branch going to the right atrium. That actually is a real branch going to the SA node. And that's the way it is in actual humans too. So off of our right coronary artery, we have immediately a little branch that goes to the SA node. And that little branch can actually be taken out, which means you take your SA node out because it needs blood supply for it to function properly. The SA node, what this is meant to show you in this picture here, the SA node is depolarizing, sending out a depolarization wave in both atria. The SA node may be located in the right atrial wall, but remember the atria also have an interatrial septum, correct? And that right atrial wall is pretty much right there where the interatrial septum is just about ready to start. So it will send a depolarization wave through the right atrium and through the left atrium. Now, why do we have depolarization waves occurring? Just to create an electrical event? Why do we depolarize anything? We want something to happen, right? So what do we want to happen here when we depolarize our atria? What do we want to have happen? Contraction. So depolarization, I want you to also relate to, is a contraction-related phenomenon, and repolarization would almost be synonymous with relaxation, correct? Because when you repolarize, then the contraction will have occurred with the muscle, and repolarization will allow things then to relax. So depolarization, contraction, and repolarization, relaxation. But this depolarization wave is going to spread throughout the atrial conduction system, and guess what the conduction system is also attached to or designed to stimulate? It's the atrial myocardial cells. So the myocardial cells of the atria will respond to the atrial depolarization wave with contraction. Now, this depolarization wave is designed to go to the AV node. We have the AV node here, and we have it here. And what's really interesting is there is an inert area between our atria and our ventricles, where we actually have no gap junctions. So we have no gap junctions right there at the border of the atria to the ventricles. If you have no gap junctions, will the myocardiocystes be able to tell, will the atrial myocardiocystes be able to tell the ventricular myocardiocystes to actually contract? They do not. And so this is really important because we have an AV node that is, in our notes here, just above the tricuspid valve in the interatrial septum that is designed to receive the impulse from the SA node and then to transmit it to the AV bundle. And the AV bundle will go into the interventricular septum. It will then divide into a right bundle branch and a left bundle branch, and you can figure out what the right goes to and the left goes to. But it's in the interatrial septum. And these bundle branches will go all the way down to the apex of the heart and then go up the outer walls of the respective ventricles that they are going to actually stimulate. So the left bundle branch will go to the apex and then go to the external walls of the left ventricle. Same thing for the right side of the heart. Then the bundle branches will then terminate in the very last item here called Purkinje fibers. So Purkinje fibers, all of these things listed here are the intrinsic conduction system parts. And they all will actually synapse, so to speak, with a myocardiocyte. And when they interact with a myocardiocyte, those myocardiocytes will have a conduction wave transmitted to them, and then with their gap junctions, they will send it to every myocardiocyte that's next to them, correct? Because that's what gap junctions are designed to do. Let's now take a look at this and assess the pattern of the action potentials and the rate of the action potentials. The SA node in our right atrial wall is actually genetically programmed to depolarize at a rate of 100 beats a minute. So spontaneous depolarization rate of 100 beats per minute. And this guy is this guy is the pacemaker of the heart. This guy, whenever they talk about cardiac pacemakers, they are always talking about the SA node. And whenever our heart rate is governed by the SA node, because the SA node can change its rate because of extrinsic factors. The rate is called sinus rhythm. So we all have the pacemaker telling everybody else what to do. Now he will adjust his rate because of fight, flight, and rest, digest, because we're all at less than 100 beats a minute right now. And so that's rest, digest. When it's fight, flight time, that rate will go up. So the master controller will change the rate based upon who's talking to him. Now, the depolarization wave will go through the atria and get to the AV node. But what's really interesting at the AV node, it will actually cause a delay, the transmission of the impulse by 0.1 seconds. This is great because it allows for atrial contraction to complete. But the AV node is also a backup node, and it has a spontaneous depolarization rate of, we're going to say 50 beats per minute. And I'm going to put plus minus. So that means the books will say 40 to 60. I decided to just go right in the middle and say plus or minus 50 beats a minute. So if you run across an elderly individual and they have a heart rate of 45 beats a minute, what do you know about their SA node? It's not working. Because there are not too many elderly people I know with a heart rate of 45 beats per minute that are actually stone cold athletes. They're usually stone cold couch potatoes, So that's their lifestyle. Life is rough and the couch is soft. So they've made their choices. Okay. So just from these obvious fluctuations of heart rate, you can tell something is going wrong with the conduction system of the heart, because the AV node is a backup. But the AV node will do whatever the SA node tells it. And so if the AV node is, if you got a heart rate of 45 or 50 or 55 beats a minute, and this is not a person that you would expect it from, it tells you that the AV node is starting to act on its own because it's not getting instructions from the SA node. As long as the SA node's there to tell the AV node what to do, the AV node will do whatever the SA node tells it. Now, the delay is indeed truly designed to allow the atria to contract, because that's what depolarization wave is going to do, cause the atria to contract. We want them to finish emptying into the ventricles, and so you'll get that instead of, but it's always the same rate as what the SA node is telling it. It just allows for the emptying of the atria into the ventricle. The AV bundle, also referred to as the bundle of His, and you might as well learn that because everybody will talk about the bundle of His, they won't talk about the AV bundle, is just below the AV node. In other words, it's connected to the AV node and in the lower part of the interatrial septum, because that's where the AV node is, and goes into the upper interventricular septum. And then divides into right and left bundle branches. And the bundle branches go down the interventricular septum. Now, the AV bundle actually has an intrinsic depolarization rate also. Of 30 beats per minute. And so when somebody comes in and they say, I can't hardly stay up, I always feel like I'm going to pass out and fall down. And you check their heart rate and it's about 30 beats a minute, you go, uh-oh, SA node's not working, AV node's not working, and now we're down to the next player to ensure the heart beats, and that is going to be either our bundle of His or even our Purkinje fibers, because that's also the intrinsic rate of the Purkinje fibers. So you know the two main players to actually keep you at a reasonable heart rate are actually taken out of the system. Now, one of the things to remember is that this AV bundle is very, very important. This is responsible for transmission of rate to the ventricles. Because I told you, we're electrically inert between our atria and our ventricles except for the bundle of His. So the bundle of His is the only communication line between the atria and the ventricles for actually beating. One of the things that we're going to learn is that the heart, predominantly the ventricles, fill predominantly passively. And you think that the atria are going to actually put a large volume of blood actively into them, but that is not the case. And the reason that you actually know this is not the case but haven't thought about it is that there are a lot of people walking around there with atrial fibrillation, and they're not getting any pacing done. Atrial fibrillation means that the SA node is not communicating with the AV node, correct? And that the atria are doing this weird little wiggling thing. They're not even contracting in any sort of rhythmical fashion. They're just wiggling around. And as they wiggle around, it's obvious that they're not dumping blood into our ventricles. And they don't have to, because the bulk of ventricular filling is a passive process. And the only thing that we're worried about for those people with atrial fibrillation is that they're going to throw blood clots. And so we give them, quote, blood thinners, which you know aren't blood thinners, they're anticoagulants. So we give them anticoagulants because one of the things that's important about blood is designed to flow, isn't it? It is meant to move. And if blood stagnates in any one place for very long, blood does the thing that it's going to do when there's a problem, and that's clot. And so when the atria are fibrillating, there's actually areas in the atria called our auricles where blood pools. And if blood pools in there, you're going to end up with a blood clot in your atria, and that's a really bad thing, because then it will then be transmitted to your ventricles, and your ventricles will then send it out to other areas of the body, which will actually clot up on you. The Purkinje fibers also have the spontaneous depolarization of 30 beats per minute. Bundle branches are in the interventricular septum. And Purkinje fibers are the ones that typically are directly responsible for making contact with our myocardiocytes and our papillary muscles. And remember, we need those papillary muscles to actually take up the slack whenever the heart beats. Quickly, before I am going to stop here, but I do want you to realize, with the depolarization wave starting in the interventricular septum, this is the area that shortens first, correct? So that's another reason why you have to understand the apex goes up towards the valves, because the interventricular septum is getting a depolarization wave first, then it's going to the atria, and then it's going to the outer aspect of the heart. And so indeed, the apex of the heart is going to come up towards our valves, and that's why it has that weird kind of corkscrew look to it whenever you actually see a real heartbeat. So we'll stop there and ask you guys a couple of clicker questions.